Hi, my name is Katerina Bush, and my father's really tongue-tied, can't use his tongue at all, and I had a frenectomy when I was 7 because I was tongue-tied, and it didn't make much difference. My tongue looked sort of normal, but I've had really bad headaches my whole life. I have scoliosis, a lot of jaw tension, a lot of problems sleeping, and I had been told that perhaps I should go see an myofascial specialist, but I hadn't done that. I actually had to do a palate expansion because I had such bad sinus infections all the time, and I didn't want to do sinus surgery. And the palate expansion helped, and it helped the headaches somewhat, but not entirely. It got rid of the sinus infections, but I still have a very small palate. And eventually after that, I decided I would go see Joy, and I would, Joy Bowler, and I would go have an evaluation. And she suggested right away when she saw how I was growing that many of my issues, including the not sleeping, including the constant headaches and the TMJ, might really change if I had a deeper frenectomy, that my adhesions, I don't know what you call them, were deeper in and were submucosal, and that they had not been disconnected in the first surgery. So I came to see Dr. Zaghi, and he agreed that this would make a big difference. And I had a tremendously forward neck when I came to see him. I was sort of like this all the time, and lots of tension all the time in the jaw, the back of the head, constant headaches. And the experience of the surgery was really amazing for me because I was scared of it because I had this botched one when I was 7. And Dr. Zaghi and his assistant were incredibly present and kind and informative, so that it wasn't so scary to do. The actual procedure was not painful or difficult really at all, but what amazed me during it was I had a need to go pretty deep to cut the cords. So what was amazing to me was that the first layer of cords, I didn't feel much, and I thought, oh, I'm going to be the one person this doesn't really change. And then the second layer, I started to feel this opening in the back of my neck, in particular where the neck connects to the spine. But the third layer, when he clipped them, it was like everything in my head and back opened up. And so now you can see that the way that I hold myself is completely different. This would have been impossible before the surgery. So in 1 second, there was this feeling of, oh, everything opened up. The pressure in my jaw is gone. The pressure in the back of my head is gone. All kinds of possibilities are opening up. I've had a little bit of a dance with my scoliosis because once things started to revise themselves, my dowager's hump, which I had a really big one, gone in 1 second flat, but now the rest of my spine has to adjust to that. So I've had a couple of weeks where things keep coming and going and they're not necessarily so comfortable. However, I seem to be coming to the end of that already, so it's only been a month since my surgery. And mostly just what I feel is this tremendous expansion and a lightness in my head, neck, and jaw that I couldn't have imagined before. When it happened, I thought, oh, this is what normal people feel like. This is how easy it can be in the world. And the fascinating thing, because I work with people's emotions, I'm a somatic therapist, is to notice in myself how from the second that those last cords were clipped, there's a sense of ease in the world for me that wasn't there before. I'm not taking anything quite as seriously. I just have a fluidity and a sense of balance that I didn't have when I was always like this. So now there's so much possibility opening up. So I'm so grateful I've had this surgery. I wish I'd had this deeper one when I was 7 and didn't have to have this long process. So I would, to any parent who has a child, if your child is struggling with headaches or sleep problems and you know that there's some degree of tongue-tiedness there, if you could gift a child with what has just happened for me at the age of almost 60, if you could give it to a young one, it'd be pretty amazing to not spend your life struggling with this tension. And those of us who have spent our life struggling with this tension, to us it's normal. We don't even know there's another possibility. But to find this other possibility now is really, I don't have words for it. I'm so grateful for it. And if you have a child who might have this issue, the surgery is minimal in comparison to the gift you could give them. So I would strongly suggest it.
Sure, I want to say that this lady is like, every time I see her, she's like so excited about this procedure. I can't tell you how grateful she is for this. And she had the ALF before, and she had this treatment and that treatment and orthodontics and, you know, injections and osteopathy. And she had everything done except this. And working together, each time I see her, she's like betterment. Really,
Thank
you're
you
my
for sending her
hero.
and
You're
preparing the
my hero.
tissues, yeah.
We should invite her to the AMS Hippocrates Gala in
So
Chicago on
I'll put it on
March 3rd.
YouTube so you guys can access it as well.
Great.
Wow.
So in this case, the way I do the surgery is I do it functionally. So the patient's awake, I put a little bit of local, and we go as needed. I don't numb up the whole entire mouth. And the reason for that is I want them to stretch their tongue up to the top, and I want them to communicate with me. It's not a 5-minute procedure for me. It takes me about 45 to 60 minutes to do this. I numb up just the front. I say reach. Then I do, I'm sorry, I'll show you how I do it. But in this case, I took it from a grade 2 to a grade 1 mobility, and I'll show you in more detail how I do it right here. So I make the frenotomy. And the frenotomy is just an incision. You're not removing any frenectomy tissue. Okay? And then upon doing the frenotomy, I have them stretch. And I use Q-tips. And then what we see is actually that underneath, she has a tethering here of the genioglossus muscle. And I'll show you more detail in another case, of another patient that's here. She has a tethering. And so I keep cutting the fascial bands until she's fully released. And I keep going, I say, how are you feeling? Do we get it? And as she's stretching her tongue, because the tissue has been prepared with joy, because it's been prepared, patients have an intuition, they have a sense of what's going on in their body. So I get one side, and then they say, you got this side, but I still put attention on that side. I get that side, and then they open up. And then we're communicating back and forth. I give a little bit more local, and then I go for it. So that kind of explains to you why I go slowly, I go meticulously, because the patient's feedback is extremely important to me, because that's how I'm going to get the results of the release, the catharsis that she experienced. And then I put stitches in, and then so this part of it will heal by primary intention, and this part's going to heal by secondary intention. And I have to leave lipids heal by secondary intention so that these glands don't scar together. The body will take care of it and heal normally. So again, we went from, it was just a grade 2 mobility, right? Is this tongue tied? Most people would say no. Most ENTs would say, get out of here, you're nuts. This is not a problem. But you can see from her testimonial that this was something that was really affecting all aspects of her life. And so I'm happy to say we took her from grade 2 to a grade 1 mobility with Joy's help with the recovery as well. So then here, and so she talks more about the emotional changes.
So I'm a somatic therapist, so I work with people's emotions all the time. And one of the things that has been the most astonishing for me in my own process after this surgery is the change in my emotional makeup. For all my life, my neck has been forward, and so my center of gravity has been outside of myself. And there's been a constant push and pull in my neck where I'm trying to find my balance in myself, but I can't because my neck had to be forward because of how my tongue was placed. The second that those cords were cut, literally the second that those cords were cut, there was an emotional shift for me that a month later is continuing to grow rather than diminish. And that is really feeling that I can come straight in and be grounded in myself. So a huge lightness has come in because I'm no longer in this struggle all the time. Nothing feels as serious, everything feels much more handleable. I had no idea this is how normal people felt, that you weren't always in struggle, always in tension. The release of not being in that struggle has an effect through all of my life. And part of it is also because when your center of gravity is out of yourself, you tend to base your life on others and on taking care of things outside of you because you can't find your own center. All of a sudden, I'm making different choices in my life. I'm in my center, I know exactly where I am, and I'm setting better boundaries. I'm much more willing to stay with myself, and I'm actually incredibly excited because it feels like every day that expands more, this ability, this thing that I didn't get to have as a kid of knowing where I was in the world. Now I know where I am in the world, and I can continue to grow from this place. So the emotional, psychological impact of this surgery is equally as big as the physical impact of not living with that kind of tension.
You can see the posture change as she experienced. So this is immediately after. So she has this forward head posture. I released the tissues in her head straightened out right away. And so the question is why? And so this is an area that you should do more research, but the reason I think why is that, so you have the genioglossus muscle here, genioglossus muscle. And the genioglossus muscle should pull the back of the tongue out of the throat. And this is what relaxes when you sleep. And this is the site of a lot of the surgeries, to move the back of the tongue forward. So now what happens in tongue ties is that the genioglossus actually bands up here to the front of the tongue. And so when the tongue is held up in the front, there's no mobility. The back of the tongue can't get any tone, it lacks tone. And so when they fall asleep, it's just, there's no tone to it, it readily falls back. Also, because of the way it's positioned, this person has to put their neck forward just to get the back of the tongue out of the throat. Because if they were to go like this, they would choke on their own tongue. So as soon as you release this muscle, the tongue comes up and out, and they can finally put their head back. That's a normal position. Another theory for why this is due to fascial bands, and I'm going to learn from Valerie about the importance of fascial release in this process as well. But this is just my theory as to why this phenomenon happens, and would love to learn from you guys and your experiences as to what we're definitely seeing this. Why we're seeing this is not entirely understood. So the next one is, I'm not going to say why I did it, but we're going to say how I did it, and I'll have Dennis come up. So come on up. So this is the patient I did 3 days ago. And I'll show you what I did. I didn't want to do it live, just because I think the patient experience is very important, and then for us to be totally engaged. And so you just join me here. Yeah, you can watch the slides. What's that? Yeah. So he was a great trooper, and I'll show you his slides and what we did just a few days ago. And then afterwards, you can ask him questions about what it's like and how it's feeling and the whole process. So this is how he came to me. How would you guys grade this? Grade 2.
Yeah.
Grade 2. Is it yes or no? Hard to say. Most people are grade 2. 68% of what I did is grade 2. This is a grade 2 tongue tie. The indications we won't talk about to protect his privacy, but we'll talk about how I do it. So the first thing, if you send a patient to me, the tissues must be prepared. Must be prepared with myofunctional therapy. So they must be able to show me the cave and hold it for about 30 to 60 seconds. They must be able to stick their tongue to the papilla. And so this is extremely important because it prepares the tissues and it allows me to make a functional assessment during the procedure. Because during the procedure, I'm going to have you stick out your tongue to the front of the cave, and I'm going to have you do cave until it normalizes to normal. Okay, so this is how we started. The first thing I do is I make a frenotomy. I make an incision.
Wow.
Just to cut all the way across. And I use a knife. If you wanted to use a laser, if you wanted to use scissors, you do how you want to do it. And then already you get some release. But then you communicate with the patient. How's it going? How are you feeling? Is everything okay? You don't get much bleeding, but I put a little gauze under the floor of mouth to control any bleeding. Make sure that their jaws aren't tense. And so each procedure I do is only about 15 to 20 seconds. Each cut that I do, I let the patient rest. And then I observe the function. So I say, show me your cave. And you can see this genioglossus attachment here. I can see it. I use a Q-tip to do the divulsion that this talked about, to isolate it. I let it rest. Open your mouth again, stretch, show me the cave. And then I actually work with, as my assistant, I have someone who's taking Joy's classes, and so she's familiar with this, and she's looking at the tongue and advising me on, where the restrictions might be, where the tension is. And we go back and forth with my assistant and the patient to figure out the minimum amount of cuts necessary to get the full function. And then, so in this case, I decided to also do, because I also decided to do a frenectomy. So I have all this tissue here that felt tethered, so I went ahead and removed this tissue, as you guys will see. So I did a frenotomy plus a frenectomy in this case. Okay? And then, so when I do the frenectomy, you can see these muscle band fibers, the genioglossus fibers, appear. I can see them more. And this is the abnormal attachment that we said. The genioglossus should go to the back of the tongue, pull it forward. But in this case, it's attaching anteriorly. It's pulling the anterior tongue forward. It's not pulling the back of the tongue. The back of the tongue is losing tone. Instead of being like a sharp muscle, it's a flat piece of meat that's obstructing the airway. So then this is after the This is after the frenectomy, okay? So you took out all the frenulum tissue, ectomy removed, and then you can still see some bands. And then if you look at his teeth, with all due respect, there's some asymmetries here. Some asymmetries here in his teeth, which tells me there's asymmetries in his tongue, there's going to be asymmetries in his frenulum that are restricting him. And so this is something that we're paying attention to as we do the procedure. So, okay. So this is the band. We're looking at it. I dissect. I use a Q-tip to dissect. I try to cause minimal trauma as possible, but some cutting is necessary. And this is an interesting slide. So you can see the asymmetry. This side is elevated a lot more than this side. And then so we dissect and we try to investigate why that is. Is there something? Is it functional or is it structural? So my job as a surgeon is to make sure there are no structural limitations here. And so we keep going. And I also evaluate the surface of the tongue to make sure I got any posterior ties in here. So I feel like I've done a pretty good job there. At this point, I feel like I've addressed all the structural issues. If you look at his tongue, it's still asymmetric. It's protruding asymmetrically. I dissect more, I divulge more. Try to figure out if it's structural or functional. And again, still has this asymmetry. But then I came to the conclusion with my go from the chin to the back of the throat. So if I cut, I would cut up here. Fascial bands here to release this muscle down.
For this patient, you can cut the muscle, you just release the face.
So I dissect in this intervention with blunt dissection. But sometimes there's still tethering here in the fascial band. It's tethered. So the genioglossus tethers to the tongue tip. So at that point, I just release some fascial bands here, and you can watch the muscle fall. Yeah.
So you're not actually removing any tissue?
I don't cut out the muscle. No. You want this muscle to be here, but I did remove the frenectomy in this case.
So and my question is, if you're not removing anything, then will it heal back to just how does it?
How do I get it to heal? Yeah.
Well,
so,
how do you get it to heal not the same way that it was before?
So the cuts that we're making in the muscle are up here, okay? And then I'll show you what happens when we put stitches in. So then this is it. And then so basically we see that there's asymmetries. We investigated that. Sorry. And then we had him sustain equally on both sides. We had him do a few clicks. And then the cave to kind of normalize it, and then we were able to get him to have more symmetric. So we knew, okay, this is functional, it's not structural. And then I put stitches in, right? So the genioglossus before was attached from here to here, okay? So now these are separated, so this can heal by primary intention. This genioglossus muscle isn't going to scar up to here again. If I did not put the stitches, then it could scar back down. The other thing that's important, especially for this area that I leave by secondary intention exercises, this is the area where you can get, so if they don't do the exercises, they'll have a grade 2 result. If they do the exercises, they have a grade 1, because this area, I can't get to the sublingual glands, it has to be secondary intention. There will be that diamond, small diamond there, it will turn white. And as it turns white over especially at the 1 to 2 week mark that Joe was saying, that's where you get the contracture in, and then the wound matures. And so it's during that period that you need to do the exercises to maximize the function and minimize the scarring that happens in this area.
So how would you topically medicate that diamond?
So this I defer to group discussion. So salt, vitamin E, coconut oil. I don't have a great idea. What I like to do is I like to help to keep it clean. So perhaps salt water or a toothbrush, but I'm open to any kind of discussion in terms of how to manage the.
Would you use a topical anesthetic?
How do the surgery?
No. Afterwards,
No, so afterwards you wouldn't do it. So before the surgery I put topical, then I use 1% lidocaine.
Okay. But
Afterwards,
for home care.
So home care, we do Tylenol ibuprofen, and then if they have a very significant muscle release, like Katarina did, very significant, you have that too. Yeah, and they'll tell you. So what happens is when I show you this.
Would you use topical anesthetic as a home care?
No,
thing?
no, not necessary.
Okay.
So what happens is all the structures are related in the throat. So even though I'm only concerned with genioglossus, the entire throat, the stylo highway, all this is going to change, and then you're going to have a very bad sore throat. You'll hear from him. You'll have shoulder tension, aches, body aches, and so for that reason, Tylenol I do give them a Norco if they need. I don't put topical anesthetics, I want them to stretch their tongue, but I send them to my functional therapist, and we have a working relationship that Joyce patients do great. So I would defer to them on how to manage a second tension wound. Okay.
I have one more question.
Yeah, and then why don't we ask, so I have more slides, but you're welcome to ask me, but if you have questions about the recovery, we can also ask Zenas, you guys can ask.
Actually, it's about the procedure. So for the frenectomy part of the procedure, you're only using a Q-tip?
I'm sorry, say it again?
Say louder.
Are you
Louder.
Are you only using a Q-tip for the frenectomy?
No, so I use medicine bump scissors, a 15 blade, pickups, and a dissector. So the frenotomy is made with a 15 blade.
Mm-hmm.
It's horizontal, this way, cut with the tongue extended, and I pick it up and I cut. For the frenectomy, well, you're removing this tissue. So first you use a Q-tip to isolate it. You don't want to injure the sublingual glands, you don't want to injure the lingual veins. Those are your landmarks. In terms of numbness, so if you go to the tongue tip, sometimes you do the frenectomy all the way to the tongue tip if it's heart-shaped. In that case, you're going to have numbness with the tongue tip, but otherwise you won't have any nerve injury either. But the more anterior you go, the more likely you get the numbness. And then it's a discussion with the patient. If it's very heart-shaped and you want to flatten out the blade, then you say, we can give you the perfect round-shaped tongue, but you're going to have some numbness from maybe 2 to 6 months. Be aware of that. Yeah. You want to say your experience, and you guys can ask some questions, no one? Yes, tell us about your experience. So this is Zenas, this is him in the pictures. He had it done 3 days ago.
Yeah, on Thursday.
Grab the microphone.
Grab the mic. I've been a long time. I'd had some sleep issues, some other issues. And I'd had a sleep study done in 2011, actually, too. And they hadn't found any apnea. And they diagnosed me with paradoxical insomnia in the late sleep phase. And I pursued a lot of interventions with respect to sleep hygiene and other stuff. And then happenstantially found a dentist who referred me to Joy. We started working together, and I noticed improvements in my sleep. I had an ALF device. And then when she mentioned Dr. Zaghi, and I'd heard that he'd come out of sleep med at Stanford, I thought, okay, this is a very interesting nexus. The surgery was kind of wild because it's very different than traditional surgery. You are participating, and at certain points you were like, "You're wincing. Are you in pain?" I'm like, "No, this is just really weird." Because it's like, and I think at one point I said, very, very much prior, I said, or right before, I said, "Should we do a metabolic panel to show efficacy?" And you're like, "No, it's going to be how you feel." And I'm like, "Yeah, right, okay." But then as you made the incisions, which is kind of this like uncanny experience because the tongue's locally anesthetized and you're cutting, and I obviously did not really want to see the scalpel in my mouth, but then this wave of tension releases out of my body, and you really do need the breaks. I felt all the muscles in my face relaxed, my shoulders relaxed. Suddenly I had to adjust in the chair because I kind of felt that much taller. And then afterwards, we alternated Tylenol and ibuprofen, which I almost didn't necessarily need from any kind of acute pain management standpoint, but more just the gestalt experience of rearranging the body and suddenly having this new tongue mobility. But I would also say I really do feel that like serenity, or just much calmer muscles, and just a presence and really vitality that I've never felt before. So, thank you. Sorry?
See an osteopath?
I'm seeing an osteopath on Thursday, yeah.
I'm sorry, I'm going back to the procedure, if that's okay. So, do you mind going over some of the anatomical structures that we should be careful of while doing this procedure, especially for the frenectomies?
Yeah, so. Okay, so sublingual glands are right here. Should we want to see it on an empty screen or one that's open? What would be best for you? Want me to go through it again from the beginning?
No, actually, you know what? I got what you already showed us. As far as the frenectomy, is there any arteries or veins or anything that you could hit?
So there's two lingual veins. Okay? So if you get into this, it'll be a slow bleeder. And if you get into it, you want to put a stitch to close it. And then just hold pressure, it will resolve. Okay, even if you put the stitch in, the stitch might fall out and might bleed. You just hold pressure and it resolves. You may have to tell the patient to do it a little bit more and to avoid the myofunctional therapy exercises. But the only thing to injure is the lingual vein here or small branches of it. So as long as you're doing the dissection, you lift up the tissue, you dissect, and you see that the frenectomy tissue is patent, it's transparent through it. There's no arteries in it, there's no blood vessels in it, you should be fine to clip it. And then the sublingual glands, like we said, and then the muscle. You don't want to cut the muscle erratically. You only want to trim it or just shave it exactly where the restrictions are to give them the release, and that's it. You're not removing any muscle.
Are you using your metronome to dissect?
No, I use a blood dissection. You could, if you wanted to, use your metronome, but I use a Q-tip. That's what I use. Whatever technique you want to use, I don't see anything wrong with that.
What do you use the metronome for?
Just to cut the fibers, just to cut the muscle fibers here, or to cut the frenectomy tissue. So I get the pickups and I remove it and I make sure it's transparent, use the Q-tip to dissect the fascia and then to excise whatever I need with this disease. Yeah, other questions? Yeah.
Would you consider having an osteopath with you during the surgery so you can also get the osteopath's input?
That's amazing if you have the resources to do that. For this, the patient's just seated there. It's just the tongue, so that's why I feel having a myofunctional therapist there is helpful. And then to follow up, for the readjustments, I find the osteopath is very helpful. But patients communicate, they tell you their experience if you're willing to listen. Yeah.
It appears to have a narrow arch. So
That's true.
are you wearing, you said you're wearing an L?
Yes.
And he's doing myofunctional therapy, and that should explain how it is. Well, it's what it was.
Good time.
Yeah.
Well, the ALF, I was for an adjustment on Monday, and we're encountering some resistance. And my hope is now with the frenectomy that you can push it out more.
I have a question about your childhood history.
Sure.
Do you know if you were breastfed?
I was, yeah.
Did you have other problems as a child, colic or ear infections?
I was actually thinking about chronic ear infections. I did have chronic ear infections. I was a little colicky as well.
Speech problems?
No speech problems. I had attention issues. I was gifted. Trying to think. Dyslexia.
Anxiety?
Anxiety. Well, that's an interesting thing because I think now people at Hopkins and elsewhere are reevaluating childhood ADHD, and in some instances it's in fact anxiety. So yes.
Do you think you had sleep problems as a child?
I most certainly did, and actually I remember I used to listen to NPR falling asleep, and I remember I was probably 12 or 11, and Bill Dement gave a lecture at the National Press Club, which I listened to. So I think that was my introduction to sleep medicine, but then I think with Dr. Zaghi, like at the start of his lecture, that I wonder about some of these parasomnias or paradoxical insomnia, if in fact they're mechanical issues, and then those exacerbate the psychological issues and so forth,
Yes.
or if they're just poorly understood mechanical issues.
And Bill Dement was the founding chair of the sleep department at Stanford and is head editor of the core sleep medicine textbook. with Christian Guimeno, is also credited to be father of the field of sleep medicine.
More questions for the answer for frenuloplasty?